Hi everybody, and welcome to our module on contraception. There are many different types of contraception. I won't talk much in this video about barrier forms of contraception, but they're very commonly used. This refers to things like condoms and diaphragms and sponges. These other items listed here, though, we will go through in the next few slides in this video and talk about the indications and use of each one. Vasectomy is a form of contraception that involves surgical ligation of the bilateral vas deferens in the male. After this is done, sperm from the testes will no longer be present in semen and ejaculate. Usually this is done as an outpatient procedure under local anesthesia, and importantly, after it's performed, a semen analysis should be done 3 months post-operatively to confirm sterility because it is possible for the procedure to fail. A semen sample at 3 months should have no sperm present if the procedure was successful. If there are sperm present at 3 months, then you do another follow-up test 1 to 2 months later. And vasectomy is considered a failure if there are sperm present in semen at follow-up after more than 20 ejaculations and more than 3 months of time has passed from the procedure. Men should be advised to use an alternate method of contraception until semen analysis has been done to confirm sterility following the procedure. And usually vasectomy is a permanent form of male sterilization. There are rare cases where the vas deferens can become recanalized. This happens in a very small number of patients. It's also possible in rare cases to reverse the procedure, but in most cases it's a permanent form of contraception and sterilization. So vasectomy is an essentially permanent form of sterilization and contraception for the male. In females, permanent contraception is called sterilization or tubal ligation. This refers to a number of surgical techniques that all have the same goal, which is to disrupt the fallopian tubes so that eggs can no longer travel to the uterus and be fertilized by sperm. A tubal ligation is often done postpartum, although sometimes they are also done outside of pregnancy. When this is the case, it's called an interval tubal ligation as opposed to a postpartum tubal ligation. This procedure has a very low failure rate. It's generally permanent, just like vasectomy, although it is reversible in some rare cases depending on which technique was used to disrupt the fallopian tubes. And then it's very high yield to note for your boards that one of the long-term risks of this procedure is ectopic pregnancy. It's very rare for pregnancy to occur after a woman has had a tubal ligation, but when it does occur, it's often an ectopic pregnancy, and that's because the egg can't travel normally through the fallopian tubes to the uterus, so the pregnancy implants outside the uterus as an ectopic pregnancy. Next, let's talk about intrauterine devices. These are contraceptive devices that, just like the name implies, are inserted into the uterus, like what's shown on the screen here. These are often inserted by gynecologists in the office, and they have a little string at the end so they can be removed. These provide long-acting contraception. We'll talk about this in a minute, but these can be left in for years in many cases, and they're also reversible. They have the string in place so they can be pulled out, and once they're pulled out, fertility normally returns very quickly. IUDs have a very low failure rate. The rate is so low it's similar to the failure rate for permanent sterilization and tubal ligation. And there are two major types of intrauterine devices. One is the copper IUD, and the other is the levonorgestrel or LNG IUD. The copper IUD looks like this picture on the screen here. It contains copper, and the idea is that the copper induces an inflammatory response in the endometrium, and this impairs sperm migration and viability. It also impairs the implantation, and that's why it works as a form of contraception. A major downside of this form of intrauterine device is that when it's implanted, it leads to heavier and more painful menstrual bleeding, and that's because of this inflammatory response. This is especially a problem in the first 6 months after the IUD is implanted, and unfortunately this often leads to a patient requesting that the device be removed because of the discomfort around menstrual bleeding. The upside to this IUD is it's marketed as a hormone-free IUD in contrast to the LNG device, which we'll talk about in a minute. And for women who choose this form of IUD and who are able to tolerate it initially, it can be left in for a long time. It can last up to 10 years. The other major type of IUD is the levonorgestrel IUD, also called the LNG IUD. This device is a polyethylene frame. It looks like what's shown in the picture here, and the polyethylene contains a drug called levonorgestrel or LNG, which is a progestin, which means it's a drug that has effects similar to progesterone. So the levonorgestrel leads to thickening of cervical mucus, which acts as a barrier to sperm. It also impairs implantation in the endometrium. Just like the copper IUD, this is a long-lasting form of contraception. In some cases, it can be left in for up to 7 to 8 years. And one of the major benefits of this form of contraception is that it causes amenorrhea in many women and it improves abnormal uterine bleeding. So the local release of LNG in the uterus often leads to amenorrhea, and that makes this a very good option in women who have heavy menses. Their menstrual bleeding will improve or stop altogether after implantation of this device. And so the LNG IUD has become very popular. It's very safe, it's very effective, and for many women it improves their menstrual periods, so this is a very, very popular option for modern contraception. Intrauterine devices do have some complications that you should be aware of. First of all, they can cause irregular bleeding or cramping. This usually resolves over the first few months after implantation, and importantly, irregular bleeding or cramping does not indicate that the device is not effective. Women will often worry about this, but you can reassure them that the presence of these symptoms doesn't mean that the IUD is not working. And then we've already talked about how intrauterine devices can alter menstrual periods. The copper IUD causes heavier periods with stronger cramping, and this sometimes leads to discontinuation of the device. In contrast, the LNG IUD can cause amenorrhea or sometimes irregular periods or spotting, but in general, the LNG IUD improves menstrual bleeding, whereas the copper IUD tends to make menstrual bleeding heavier and more intense. A rare complication is uterine perforation, so the device can perforate through the wall of the uterus. This is often asymptomatic, and it's identified when the IUD string is not felt. So as I said before, there's a string attached to the IUD, and if the IUD goes through the uterine wall, then the string will no longer be felt, and women will sometimes report this, and that's how a uterine perforation is recognized. Rarely the perforation can lead to symptoms like pelvic pain or excessive cervical bleeding. And then you should also be aware that intrauterine devices can fail and lead to pregnancy, and when they do fail, usually the pregnancy is an ectopic pregnancy. It's very difficult for a pregnancy to implant in the uterus when there's an IUD present, but these pregnancies can implant in the fallopian tubes or outside the uterus, so when IUDs fail, they usually lead to an ectopic pregnancy. There are some contraindications to intrauterine devices you should be aware of. First of all, some anatomic uterine abnormalities preclude insertion of the device. So if women have a bicornate uterus, sometimes you can't place the IUD. Same thing if women have leiomyomas or fibroids. This can make it hard to get the IUD into the uterus. These aren't always absolute contraindications. Sometimes the IUD can be placed using ultrasound guidance, but the point is that the presence of anatomic anomalies like this make it harder to insert the IUD. IUDs shouldn't be inserted in women who have unexplained uterine bleeding. You should work up the uterine bleeding first before you insert an IUD. They're also contraindicated in women with pregnancy or pelvic infection, and in women who have endometrial or cervical cancer. And then for the levonorgestrel IUD, because it releases a progestin, women who have progesterone receptor positive breast cancer should not receive this intrauterine device. Also, for women who have active liver disease, this can potentially lead to problems metabolizing any progestin that gets absorbed, so this is generally also considered a contraindication to the LNG IUD. Okay, moving on, now let's talk about hormonal contraceptives, and this refers to using drugs that function like the natural hormones progesterone and estrogen or estradiol. Some hormonal contraceptives function as progestins. These mimic the effects of progesterone. The major mechanism of contraception for progestins is that they thicken cervical mucus, which limits sperm mobility. They also thin the endometrium, which prevents implantation. If you give them at high dosages, they block the LH surge, and this will lead to an absence of ovulation. But for most dosages of progestin drugs, this is not the major mechanism. It's the first two here, the cervical mucus changes and the thinning of the endometrium. When estrogens are used as hormonal contraception, they suppress FSH release from the pituitary gland, and this limits follicular maturation so that ovulation is less likely. They also enhance the effects of progestins, so when you give estrogens together with progestins, you get more progestin effect. But really the main reason that we give estrogens as part of hormonal contraception is because they stabilize the endometrium, and this leads to less breakthrough bleeding. As we will see, you can use progestins alone for contraception, but there's lots of problems with breakthrough bleeding. If you use them together with estrogens, there's less breakthrough bleeding, and this makes it easier for the patient to tolerate the medication. So like I said, you can use a regimen of only progestins, and that can work for contraception. There's an oral progestin that's sometimes used for this purpose. It's called norethindrone. It's also called the mini pill. Its main benefit for contraception is that it thickens the cervical mucus for 20 hours. Because the effect is so time limited though, women have to take it at the same time every day, and this is difficult to do, so this is a very rarely used form of contraception. There's also an implant of a progestin called etonorgestrel. It's placed in the upper arm, similar to what's shown in the picture here, and it will release etonorgestrel over a 3-year time span, so this can last for up to 3 years, providing contraception. The problem with this is, as I mentioned on the last slide, when you give progestins without estrogen, there's lots of irregular bleeding, and that's a major issue with this implant, and that limits its use. There's a form of progestin-only contraception given by injection. The drug is called medroxyprogesterone. It goes by the trade name Depo-Provera, and many people simply call it a depot shot because it's given through injection like what's shown on the slide here. It's given every 3 months in the office, so this is an option for women who don't want to have to take a pill every day. They can simply come to the office every 3 months for a depot shot. In terms of side effects, it can cause irregular bleeding, just like you can see with any progestin-only contraceptive. And then another side effect of the depot shot is that it often causes weight gain. So for example, one study found that at 3 years, women who received depot shots for contraception gained 11 pounds compared to about 3 pounds on women who take combined oral contraceptives. Many contraceptives cause weight gain, but depot shots are sort of famous for causing more weight gain compared to other options. And then you should be aware that besides contraception, there are many non-contraceptive uses of Depo-Provera. I talk about this in other videos, but in conditions like endometriosis and adenomyosis, Depo-Provera can be helpful. Same is true in abnormal uterine bleeding or fibroids or endometrial hyperplasia. In all of these conditions, the effects of a progestin compound like medroxyprogesterone can improve symptoms and clinical features. As we've been discussing, all of the progestin-only contraceptives are associated with irregular bleeding, and this is the major drawback to progestin-only forms of contraception. Usually progestin-only contraception is used in women who can't take estrogen for some reason. We'll talk about some of the contraindications to estrogen later in this video. Progestin-only contraceptives are also not used in women with breast cancer out of concern that the progesterone effects could drive growth of the cancer. And then you should be aware that there's a long-standing association that's been established between Depo-Provera shots and low bone mineral density. This is believed to occur because the Depo shot suppresses estrogen production, and this reduces bone mineral density. It has, however, been shown that bone density improves once you stop taking the Depo shot. And so the current guidelines recommend that in any woman receiving Depo-Provera, you should encourage her to take enough calcium and vitamin D and to get enough weight-bearing exercise, but you don't need to do any routine monitoring of the bone mineral density because, as I said, it's going to improve once she stops taking the contraception. You should also be aware that progestin-only drugs can cause mood changes. In particular, they can cause depression, so you have to use caution when prescribing these drugs in a woman who may already have issues with depression. And then lastly, you should be aware that all of these adverse effects are very rare with progesterone IUDs like the LNG IUD we talked about earlier. There's very minimal systemic absorption of LNG, so these adverse effects are relatively uncommon. Okay, moving on, now let's talk about combination oral contraceptives. This refers to drug regimens that contain a combination of a progestin component and an estrogen component. As we've been discussing, you don't need estrogen for contraception. Progestin compounds alone will work, but there are a couple of benefits to adding an estrogen component. First of all, you get better suppression of follicular growth in the ovaries. Progesterone suppresses LH and estrogen suppresses FSH, so using the two drugs together make it less likely that ovulation will occur. Also, as we've already discussed, estrogen increases the effects of progesterone, so you get more progestin effects when you give progestin drugs together with an estrogen. But then really, as I mentioned earlier, the main reason we add estrogen components to contraceptive regimens is because this leads to less breakthrough bleeding. Estrogen stabilizes the endometrium, and it prevents that problem of irregular bleeding that is a major drawback to progestin-only contraception. And then you should know that many modern formulations of combined oral contraceptives have a 24/4 formulation. By this I mean that women take the pill every day during their cycle, but 24 days they are taking a hormone pill, and on 4 days they are taking a placebo pill. The idea here is that when they take the placebo, there will be an absence of hormonal effects on the endometrium, and that will lead to menstruation. So by doing it this way, women have very regular and carefully controlled menstrual periods on the days they take the placebo pills, and they usually have no breakthrough bleeding on the days they're taking the hormone pills. Besides preventing pregnancy, combination oral contraceptives have a number of non-contraceptive benefits. First of all, they lower a woman's risk of ovarian and endometrial cancer. They also make menses very predictable and generally lighter, and in the video on abnormal uterine bleeding, I talk about how combined oral contraceptives are a major treatment option for many forms of abnormal uterine bleeding, and that's because they make menses more predictable and lighter. And then lastly, combined oral contraceptives have been shown to improve acne, so for many women this is an additional benefit of taking these drugs to prevent pregnancy. There are some adverse effects of combined oral contraceptives you should know about. First of all, the most common adverse effects are nausea and headache, especially when initially starting the drug. Breakthrough bleeding can also occur in women taking these drugs. It's more frequent the lower the estrogen component. Remember that the estrogen limits breakthrough bleeding. So in formulations with very low estrogen components, and there are some of these, breakthrough bleeding is more likely. Importantly, breakthrough bleeding doesn't indicate decreased efficacy of the drug, and usually this resolves spontaneously and improves with time. The estrogen component of these drugs can raise the blood pressure, so women can develop hypertension. It's usually mild. And then the estrogen component can also lead to thrombosis. Estrogen increases the number of clotting factors in the blood. This raises the risk of thrombosis. Usually it's venous thrombosis like DVT or PE. Rarely women on these drugs can have arterial thromboses like stroke or myocardial infarction. Shown on this slide are the contraindications to the estrogen component of combination oral contraceptives. So women who are smokers who are over 35 years of age have a risk of DVT or thromboembolism on combination oral contraceptives that is so high that the drugs are contraindicated. And it's super high yield to know that this group of women cannot take combination oral contraceptives. These drugs are also contraindicated if women have a history of DVT, pulmonary embolism, stroke, or MI. This is all related to the increased risk of thrombosis on oral contraceptives. Estrogen can drive the growth of breast cancer, so women who have a history of breast cancer often do not take these drugs. In the gastroenterology section, I talk about a rare lesion in the liver called hepatocellular adenoma. These liver tumors can grow and even rupture if women take combination oral contraceptives. So estrogen-containing contraceptives are contraindicated in this group of patients. The only contraceptive approved for use in this group of patients is the copper IUD. Even the LNG IUD is considered to have risks that outweigh the benefits. Because oral contraceptives are metabolized in the liver, cirrhosis or advanced liver disease is generally considered a contraindication. And then among women who have a migraine with aura, there's a well-documented increased risk of blood clots when they take combination oral contraceptives. And the risk is high enough that these drugs are considered contraindicated. Some studies have found that when women who have migraines with aura take combination oral contraceptives, their risk of blood clots doubles or even increases further. The reason that this happens is not well understood. And then lastly, because estrogen components of oral contraceptives raise the blood pressure, hypertension is a contraindication. The CDC says that a systolic pressure over 140 or a diastolic over 90 is a contraindication. The WHO has a little bit different cutoffs. They say a systolic over 160 or a diastolic over 100 is a contraindication. And then I'll finish with one slide on postpartum contraception, which is a special situation. So for women in the immediate postpartum period who are breastfeeding, lactational amenorrhea can prevent pregnancy, but this is unreliable. And so for women who don't want another pregnancy right after delivering a baby, they often want some form of safe contraception. Barrier methods are an option in this period, but these are inconvenient, and many women want something that is more reliable than this. And the thing you need to know about the postpartum period is that estrogen is generally avoided at least for 1 month, but often longer. In the first month after delivering a baby, there's a high risk of thromboembolism if a woman takes an estrogen-containing contraceptive. Also, estrogen suppresses breast milk production, so in any woman who is breastfeeding, usually an estrogen-containing drug is also avoided. So for these reasons, common options in the postpartum period are the IUD or a progestin implant. The copper IUD is one option, but as we talked about earlier, it can cause bleeding, so this needs to be avoided if women have ongoing bleeding after delivering a baby or if they have anemia after delivering a baby. The LNG IUD is a popular option in this scenario. There is a small risk of expulsion because the uterus can still contract in the postpartum period, but so long as you monitor for this, the LNG IUD is an option. And then postpartum is one situation where the progestin implant is often used. It's more reliable than pills, and like I told you earlier, progestin implants often cause irregular bleeding, but there's actually less irregular bleeding in the postpartum period when women are breastfeeding because other hormone levels are high. So in the postpartum setting, a simple option is often to implant a progestin implant like what's shown in the picture here and leave it in place until the woman is done breastfeeding, and then it can be removed and she can go back to estrogen-containing contraceptives. And that concludes our module on contraception.